there's a drop of thrombolysis, no more thrombolysis in Western world. But in Asia, especially in Thailand, Vietnam, Malaysia, Laos, except Singapore, we still have to use the thrombolysis because of the non-PCI capable centers for as a nationwide center for the whole country. And we have a new anticoagulant. The new anticoagulant study after 2000 is the low-level heparin. The most important one is extra 2025 when you use the unfractionated heparin. And the new bivalirudin as an anti-factor 10A or hero 2 and OA6. These was a post-2000 study. Look at the STEMI diagnosis and STEMI discharge. You can see that the PCI has been increased. Can I have a pointer? It's just very faint. So this is the from 2002 to 2010 STEMI discharge and in-hospital day. You can see that the in-hospital mortality has been increased from year 2000 to 2010. And the number of the discharge and PCI is increased. You can see that PCI is increased in 2010. And in many countries, PCI is the major reperfusion strategy in acute infarction. Determinant of blood vulnerability, we have a vulnerable blood rupture of big catheterizoma, disruption, and then we have the unstable coronary disease, rupture, brain application, and we have the lysis of repair. And determinant of the thrombosis, we have local factors, systemic factors, and downstream embolization. And with these, after recognization, the patient has been treated. And if you look at these parameters in the plot, you can see that there is a numerous difference in characteristics. Fibrous tissue, anteromatous material, thrombus, plaque hemorrhage, macrophage, and smooth muscle cell. And we start from the thin catheterizoma. Transfusion rupture is the main mechanism of the acute infarction, with platelet adhesion, platelet aggregation, and formation of thrombus. And if the thrombus is clear, it is non-occlusive thrombus and non-acceleration acute syndrome. For acute occlusive thrombus, there is no perfusion, and then EKG shows AC segment elevation. So chest pain, acute syndrome, acceleration, non-acceleration. We have from the first speaker that troponin came to be a new modality for diagnosis of acceleration in mind with high sensitivity but a little bit low specificity. Most important one to always remember is chest pain. There's a muscle chest pain more than 20 minutes with signs and symptoms of acute infarction like perspiration, fainting, complication, or whatever. And then after EKG, you make a diagnosis of acceleration or non-acceleration. And final diagnosis can be acute infarction followed by the rise and fall of the troponin. The history of patient illness. Time of chest pain, molecule pain, associated symptoms. Pain is reproducible by the breathing complication, change in the posture. Recent pain compared with previous diagnosis of angina is worse, similar, or better. EKG time, ED arrival time. The 6 medication that should be considered: aspirin, clopidogrel, loading dose, half dose thrombolysis, heparin loading dose, heparin infusion. And if there is no cardiovascular lab, 10 KTPA should be reviewed. And for primary PCI, the most important part is around time. Procedure start, balloon inflation, cockpit artery, cockpit TB flow, post-procedure TB flow, and post-procedure TB artery perfusion. That is most important for the revolution. And then step for is in emergency department record. This is the coagulation cascade. We just separate between this is above for white thrombus and below is red thrombus. White thrombus is the majority is the blood cascade. Red thrombus is coagulation cascade. And there are numerous drugs that treat to inhibit bleeding. Most important that we use for more than 100 years is aspirin, and then people believe covidinol and now Cosintral and Candelol to inhibit the P2Y valve to decrease the platelet aggregation, to decrease the platelet cascade. EKG of SA second elevation, SA second elevation from B2 to B5. In the past we call anterolateral wall infarction, now we call proximal LAD occlusion. This is a EKG for the SA elevation in the 2-3 AVF and SA elevation in B2, SA B1 and B2. And these could be categorized into either right coronary artery occlusion or left circumflex coronary artery occlusion. You know about the Custom 2B EKG classification. This is for correct correlation between EKG SA segment and anatomy and mortality. This is a classification by anatomy, by EKG entry, 30-day mortality and 1-day mortality after thrombolysis. The proximal LAD is SA segment elevation from B1 to B6, 1 AVL, and vascular block or the branch block. 30-day mortality after thrombolysis is 19%, and 1-day mortality is 25%, about 4. This is the most severe, most significant infarction, proximal LAD. And in the past we call anterolateral. Mid LAD, distal LAD, moderate to large inferior and small inferior. Go ahead to EKG. Mid LAD, SA segment elevation from B1 to B6, 1 APL. And distal LAD, inferior and small inferior. The mortality has been decreased from the anatomy. And treatment delay is treatment denied. Symptom recognition, call to medical system, pre-hospital triage, emergency room department, and CAT. The bar X here is not happen in Asian country. In Asian country, we don't have the effective call to medical system. Patient has to transfer by themselves. We don't have pre-hospital triage. We don't have pre-hospital thrombolysis. And patient has to come from here, symptom recognition to emergency department. And there is always a delay in ED and increasing loss of myocytes before going to CAT. So occlusive thrombus in SA segment elevation, large area infarction, there's a clot in the coronary artery. Oxygen and thrombolysis is the mainstay. Aspirin and other treatment. Fibrinolytic is easy to use. Primary PCI is not essential. So this is the evolution of strategy to reduce MI mortality. It improved in patency, improved in microcerebral perfusion, and treat shock more effectively. The most effective way is carrying PCI plus TB2B3A or drive-eluting stent and field administration of the thrombolysis of pre-hospital triage, a combination therapy with full lower heparin on the apparatus or reduce the dose TB2B3A of pharyngitis. It effective